Hello everyone, I am Shankar. Today I will be talking on the topic adenocarcinoma of colon, the risk factors and pathogenesis of it. So let's start with the case history. On a routine health checkup and laboratory evaluation, a 65-year-old male was found to be having microcytic hypochromic anemia. His stool sample was positive for occult blood. A colonoscopy was performed and showed a 4 cm bulky, exophytic, cauliflower like polypoid lesion projecting into the cecum. Biopsy was performed and microscopic examination confirmed the clinical suspicion. What is the probable diagnosis? So let's discuss it afterwards. What is the probable diagnosis? Let's look at the other case. A 70-year-old man complained of change in bowel habits for the past 1 year. He also complained that the defecation was more difficult. Physical examination did not reveal any significant findings. His stool sample was examined for occult blood and was found to be positive. Colonoscopy showed an annular lesion encircling the descending colon. Biopsy examination confirmed the diagnosis and was followed by colonic resection. So, what is the probable diagnosis? So, let's talk about the risk factors of adenocarcinoma of colon. The major risk factors are diet or animal fat, hereditary syndromes, inflammatory bowel disease. So, in diet animal fat, we can see that there is insulin resistance, fiber, deficiency of vitamin A, C, and E. So, let's understand how decreased fiber leads to the adenocarcinoma of colon. Decreased fiber means decreased stool bulk, which alters the composition of intestinal microbiota. It means that the normal flora which exist in the intestine are altered, making it the potential risk factor for the adenocarcinoma. So, if there is increased fat intake, increased hepatic synthesis of cholesterol and bile acid takes place, which is converted to carcinogen by intestinal bacteria. And also deficiency of vitamin A, C, and E, which helps in enhancing the absorption from the intestine, also are the potential risk factors. What are the hereditary syndromes? These are the syndromes which are inherited by birth. For example, polyposis coli, MYH associated polyposis, non polyposis syndrome, also known as Lynch syndrome. Inflammatory bowel diseases such as ulcerative colitis and Crohn's disease are also the potential risk factors. Other risk factors such as Streptococcus bovis bacteremia, increasing age, family history of colonic cancer in first degree relative, prior colorectal cancer also play the role for development of adenocarcinoma. Factors that reduce the risk. Factors such as diet rich in cruciferous vegetables like cauliflower, sprouts, cabbage, and vitamin A. Aspirin and other NSAIDs exert a protective effect on the intestine. So let's talk about the pathogenesis of the adenocarcinoma. Here, two distinct genetic pathways has been described. It is classic adenoma carcinoma sequence and microsatellite instability pathway. So let's see about the adenocarcinoma sequence. In the first image, we can see that there is a normal colon with mucosa, submucosa, muscularis propria, and serosa. So, germline or somatic mutations of cancer suppressor genes. It is the first state. Means there is change in the germline. There is germline mutation in the somatic genes like APC at 5q21. And when there is the mutation, the mucosa is at the risk of development of adenoma. Methylation abnormalities, inactivation of normal alleles. It is the second hit. Change of APC at beta catenin. When there is this, we can see that there is development of adenoma in the third picture. Proto-oncogene mutations such as KRAS at 12p12. Homozygous loss of additional cancer suppressor genes, overexpression of COX2. There is also P53 change at 17p13, LOH at 18q21, SMAD2 and 4. After that, additional mutations, gross chromosomal alterations happens and telomerase and many genes alters which make it potential risk for development of carcinoma. Microsatellite instability pathway. Let's discuss about this. The microsatellite instability pathway associated with DNA mismatch. It is associated with DNA mismatch repair. Normal colon. Mutations of mismatch repair genes MLH1, MSH2, MSH6, PMS1, PMS2. Normal colon have these genes. Sessile serrated adenoma, microsatellite instability or mutator phenotype. Carcinoma, accumulated mutations regulating growth, differentiation, apoptosis, which make it development for the adenoma. Let's see where is the most susceptible site for development of adenocarcinoma. We can see that rectum 38%, sigmoid colon 20%, descending colon 10%, hepatic flexure 8%, transverse colon 6%, rectosigmoid junction 7%, cecum 8%, and splenic 2%. So in the left colon, the pain is around 60%, mass is 40%, bleeding is 20%, change in bowel habit 60%, weight loss 15%, vomiting 10%, obstruction 20%. Whereas when it shifts to the right side lesion, pain is 80%, mass is 70%, rectal bleeding 20%, diarrhea and change in bowel habit is around 40%, weight loss, vomiting, and obstruction. When it comes to the rectum, pain is reduced to 5%, mass is almost negligible, bleeding is highest in this area, change in bowel habit is 80%, weight loss is around 25%, vomiting 0, obstruction 5%. So, what are the clinical features of the left sided colon cancer and right sided colon cancer? Left sided colon cancer is annular napkin ring construction like ulcerated in mid region. Distal colon annular lesions causing napkin ring constriction. These produce occult bleeding, altered bowel habits, or pain and discomfort in the left lower quadrant. Right sided colon cancer. Microsatellite instability, polypoidal, exophytic. Proximal colon, polypoid, exophytic mass. It's present with fatigue and weakness due to iron deficiency anemia. Iron deficiency anemia in an older man or postmenopausal woman should be considered due to GI cancer until otherwise proved. So it was my topic about adenocarcinoma of colon. So I will end the topic with this. Thank you.